As you have heard already a lot about the posterior fossa, I will try to keep this short. So what about human infratentorial development? Human infratentorial development goes on for a long time. It starts about at gestational week 6 to 7 and goes on further to postnatal stages. So during this long time, there is also a lot of time that things can happen to impair infratentorial development. Well, now we heard a lot about the cerebellum. However, the cerebellum and the brainstem is a functional unit. And so I think, and from the point of view of the MRI, we also have to look at the brainstem. What are we dealing with? We are dealing with malformations, acquired pathology, and so-called disruptive development. Let me start with some definitions but before I would like to show you a spatiotemporal model of brain development derived from MRI data, starting at gestational week 18 and going to gestational week 34 or 36. And in this model, you will see the movie, the structures in red are developing. And as you will see, the cerebellum, the infratentorial regions are red all the time. So some developmental steps of the infratentorial region are taking place all the time during pregnancy, and all the time something may go wrong. An injury to the developing brain just in common may result into an abnormality or anomaly. What is this? It is an abnormal structure but with preserved function. We just heard about the megacisterna magna. That is per se not a malformation that has a consequence. A malformation is an abnormality that is not only morphologically abnormal but also functional. Look at this brain. An acquired lesion is an impairment of a previously normally formed structure, such as a hemorrhage, and then, and especially in the cerebellum, we may deal with the fact of disruption, which is a maldevelopment based on the damage of an immature organ. That means if an insult happens, then something is damaged, but development still goes on, and development may go to a certain level, but may never be normal there. On MRI, we follow a step-by-step analysis. I can go over that very briefly because everything has been said. The position of the tentorium may be too high, normal, or too low with the respective malformations. Here, I will just go very quickly over these cases. Both of them are Chiari 2 malformations because you see the spinal defect and you see the brain. But the outcome, here you see the brain with a very small posterior fossa and the vermis and other parts of the cerebellum protruding into the cervical spinal canal. But here, the posterior fossa is also small, but even the fourth ventricle is preserved after birth. The difference is this is myelocystocele and this is myelomeningocele. This is open and this is closed. I know this morning we heard that in closed spinal dysraphism we don't have a small posterior fossa. Well, in some we have, because it depends on the CSF pressure that can be present. If the spinal cord is closed, then there is some CSF pressure that is necessary to form a posterior fossa. If there is a cyst, the pressure may be less intense and the posterior fossa may be small. So this is after the hydrodynamic theory of McClone and Neidig, but it is true for these malformations. And we also did a study where we looked at the angle, at the position, and here you see the occiput clavus angle, and here in normals, in closed defects and in open defects, and the angle was almost the same in the closed neural tube defects as in the normals, but it was clearly too steep in the open defects. The fluid spaces may be reduced, enlarged, or there may be a mass effect enlarged in the Dandy Walker. In the Chiari 2, it will be reduced. In the Megacisterna magna, it will be enlarged, and when you have an arachnoidal cyst, there may be some compression on the cerebellum. The shape of the fourth ventricle. These fourth ventricles in gestation week 20 and 36 are of normal shape. Here you have a tactile malformation with a dysplastic cerebellum, and therefore the fourth ventricle does not look as it looks in the normal case. And here, of course, it is not normal because it is corresponding to the cyst. And here we have post-hemorrhagic hydrocephalus leading to a wide fourth ventricle, which is also here with a very steep fastigium, and in the Chiari-2, it may be very small. The primary fissure of the vermis, it should be present on MR image at least at gestation week 24, but if you have your good image quality, you can see it earlier, and it is important because it gives you the proportions of the vermis, which are like the golden section, like the Mona Lisa, and the ratio of the posterior to the anterior lobe should be preserved. If it is not, as it is here, then the cerebellum is dysplastic, as for instance associated with lissencephaly type 1. We already discussed a lot the Dandy-Walker malformation, and there are papers, there are indications if you can see the sulcation of the vermis, and more important, the supratentorial regions are completely normal, then the prognosis is not that bad. So what does it mean, not that bad? Well, I just show you a case of our own series. You see this one, gestation week 26, and with 3 years. In the meantime, he's in school age and he is developing very well, but he's not good at soccer, which in Austria is not really an issue. In your country it is, of course. Well, is there a condition where there is no vermis? Of course there is, because Gianluigi showed us one. So what is this? If you look here, this looks like a formation you usually have in the mouth. It looks like a molar tooth, and you also see there is an associated malformation, a kidney malformation, and an atretic seal, which is also part of the Joubert continuum. Usually, you know how we do get these patients. Well, we get it because of the kidney situation. So it is really important for us to look at the whole fetus and not only at the kidney, because the main diagnosis would have been missed. If you have a very small vermis, so this is your diagnosis, you have vermis hypoplasia. Well, it is part of your diagnosis, but look at this fetus. Something is very wrong here with the whole fetus. We have a hypoplastic vermis, we have subcutaneous edema, we have splenomegaly, and we have a liver malformation. Now it is easy to do a diagnosis. So what is your diagnosis? It's already part of the quiz. Sorry? This is a congenital disorder of glycosylation. It is a metabolic disease, and there are only a few metabolic diseases that lead to disorders of anatomy and morphological changes, and this is one of them. Size of the vermis. Well, if you are a fetus in gestational week 12 and you have only a small uprotated vermis, that's fine, because you know it will become bigger and rotate downwards eventually. Unfortunately, all of us know fetuses where it is not quite okay in gestation week 22. So what should you do? Well, perhaps this is a form of delayed opening of Blake's pouch, but usually if you wait, it might become normal later on, but of course only if you don't have associated malformations as here. Well, here where you have really microlissencephaly, here is the small vermis a part of the syndrome. But what's the matter here? Gestation week 90, it looks strange. Gestation week 20 plus 2, it looks better. And gestation week 24, it looks normal. We had already discussions on previous courses, and I know there are people who observed the other way round, that a normal vermis became abnormal. I have never seen it, but perhaps you have seen it. Do we need measurements? Well, this is a fetus gestation week 24. Question is this rhombencephalosynapsis? You look sagittal slice, you say yes. You look coronally, you say no. You look on the axial slice, you say yes. Okay, so what is it? You can measure. Oh, and the measurement, it is the area of the vermis is above the normal value. So what you are measuring is probably not the vermis, but a hemisphere, and so this is rhombencephalosynapsis. Hemispheres, dimensions, you know, you can measure it. It's the same on MRI as on ultrasound. The normal values are widely overlapping. And when you look at the hemispheres, what you look is, are they normal? No, this is rhombencephalosynapsis, or abnormal, or are they symmetrical or not? There is unilateral damage. This is Dandy Walker, and here you see of the unilateral damage too. And there is a clear destruction. And then you have situations like that. Gestation week 23, there is hemorrhage. And gestation week 28, there are still residuals of hemorrhage, but the hemisphere is still developing. And gestation week 32, you have a slight smaller hemisphere on the right side. And this is what I meant with disruptive development, because it's almost normal, but there has been some damage, and after the damage, the cerebellum continued to develop. You look at the signals. You have hemorrhage infratentorial, and there is something, we go on, do a control, there is a space-occupying lesion, and this turned out to be a capillary hemangioblastoma that could already be diagnosed very early. The pons. If you're a fetus in gestation in week 11 and have a pons shaped like an S, that's fine. If you're older, that's not fine anymore, because here you have still an immature shape of the pons, and this is a feature of lissencephaly type 2. I showed you this case already in the morning, and here is the pathology. The pontine bulge should be present very early. You should see it at least at gestation week 18. If it is too small or absent, it is not a good sign. You see, the pontine bulge may be absent because of lissencephaly type 2, because it is compressed, as you can see here, by a retrocerebellar cyst. Of course, we have normal values, but if it looks like that, the pons can't be normal, and in contrast to the vermis, if it looks like that, it will not become normal ever. Pontocerebellar dysplasia, pontocerebellar hypoplasia. There are a lot of types of PCH, but you probably know the work of Peter Barth, and he has defined distinct types of PCH, and we are interested to find these types because we know the genetic background. And to date, it was hardly possible to do this diagnosis prenatally, but this fetus, in comparison with this normal one, fulfills three facts that you should see. It is polyhydramnios in addition to pontocerebellar hypoplasia and IUGR compared with this fetus, and so you might suspect this is a hereditary or a mutation, a pontocerebellar hypoplasia with a genetical background. Associated anomalies, of course, here we have rhombencephalosynapsis with lissencephaly, and you can have any abnormalities you choose. And what about myelination? The cerebellar peduncles are among the earliest structures to myelinate. And we even see pre-myelinating changes on our diffusion-weighted images. We can try to do tractography. It's very difficult in infratentorial structures because they are so small. We can look at myelination because myelination is displayed as dark signals on T2-weighted images, but as I told you, these structures are so small, so we had to look at other possibilities to assess brainstem maturation. Because you know a lot of functions are located there, a lot of functions that are already active rather early in pregnancy. So first think what we tried to reproduce were eye movements described already about 30 years before by Bernholz. Here you have those with the rotatory component, and here we have the nystagmoid movements. And then we went a step further and quantified these eye movements by a computerized method where we could calculate away the movements of the head and look at the movements of each eye separately. And then you will ask, you are sleeping already, I know. Why do they do that? Well, because, you know the vestibulo-ocular reflex. What the vestibulo-ocular reflex is a very primitive reflex, and perhaps let's make an experiment. Please look at me. Please look at me. You saw me sharply all the time? Yes? So I can tell you something about your brain function. You are not brain deaf. Because we are using this reflex to test in brain deaf patients or in comatose patients whether the primitive reflexes are still functioning. Because you need a lot of brainstem structures for this reflex. You need functioning inner ear. Well, the inner ear is major about gestational week 20 weeks, and then to make this reflex working, you need a function of all these cranial nerves, the nuclei of which are located in the brainstem. And this is what it looks in the fetus. The fetus turns the head and the eyes stay already centered. This is possible to see after gestational week 30. So if we see this, we learn a lot about the nuclei of the cranial nerves in the brainstem. And of course, our science has gone further, but I am not allowed to tell you that we have already located the cortical representation of these movements. So please take home, prenatal MRI can define infratentorial pathology. In isolated abnormalities, prognosis is difficult, especially early, and tractography and eye movement analysis may be helpful in the future. Well, if you really want to pay a lot and you want to go to get unnecessary information 2 days long, please come to Jena.